All right, welcome back. Another lecture on diabetes. Today, this is bread and butter primary care. I'm Dr. Stokes. We're going to talk about use of insulin in type 2 diabetes. So there's other videos. We talked about metformin. We talked about sulfonylureas. We talked about the other oral medications that are available. We talked about the injectables that are non-insulin and those types of things. And so then the question comes, at what point does insulin become necessary and advantageous in the treatment of type 2 diabetes? Now remember, in type 2 diabetes, the pathology is that their insulin doesn't work well. Okay, so the insulin's there, but the cells don't respond to it. So you will expect, if you do use insulin, and you oftentimes will use insulin in type 2 diabetics, it takes a lot more insulin than, say, a type 1 diabetic because they're insulin resistant. Their cells don't respond to it. And so sometimes there's a sense that if you aren't doing well with the pills and other medicines, you have to use insulin. That insulin is some sort of failure on the part of the patient or the part of the doctor, kind of like your diabetes has gotten bad enough, now you need insulin. And people tend to be like, I don't want insulin, I don't want insulin. It's not really how it works. Insulin is one of the many medications that can be used to control a type 2 diabetic, and there's pros and there's cons, and some patients it's going to be very helpful. Some patients it's not the right choice. And so it's not an issue of, well, you have really bad diabetes, so you need insulin. And this person doesn't have bad diabetes, so they're fine with metformin. It kind of depends. Another thing that oftentimes you hear people say that I wanted to bring up is that if you ever have a patient who has an A1C higher than 10, that they're going to need insulin. Now, that is generally true. What people are saying when they say that is the studies they've done on the oral medications and the injectable medications that are non-insulin is that for each medication, you can get about a point to a point and a half drop in the A1C. So if a person's above 10, right, so let's say they have an A1C of 11, in order to get them down to a 7, you would need like 8 medicines, 6 to 8 medicines. And so are you really going to have them on like 5 pills and 2 injectables in order to get them down there, or are you just going to use insulin? That's what they're saying when they say if the A1C is above 10, you need to go straight to insulin. The only thing I disagree with is people who are new to diabetes and have not yet made any sort of dietary or lifestyle changes, because that is huge with control of sugars and diabetes. And so if I have a person who's brand new, they were in the hospital for a urinary tract infection and they were told they had a bunch of sugar in their urine, we do an A1C and it's 12, I don't say, ooh, you're above 10, we're going to put you on insulin. It wouldn't necessarily be wrong to put that person on insulin, but they don't even know they have diabetes yet. If that person cuts back on their carbohydrates, starts walking every day, they can drop. I have seen people drop from a 12 down to a 7 and in that range with just metformin. Now, it's not because metformin is powerful enough to make that drop, but it's because of the lifestyle changes and the things that they do. You know, they used to drink 3 sodas a day and now they're not. That's a massive decrease in sugar and is going to bring that number way down. And so people tend to prefer oral treatment, pills and non-insulin treatment. And so I always have a conversation with the patient and we work it out together, what they think would be best, what I think would be best, and what works better. Because another important thing is buy-in. The patient has to want to do the treatment. They need to be into it. If you prescribe them something that they're not going to do, then it's not worth doing anyway. So let's say you've got your patient, they've been on metformin, they've been on several other oral medications, you've tried some injectables, and you just cannot seem to get the A1C under control. You have a conversation with them and decide, you know what, it's time to, let's try insulin. So how does that look like? How do you initiate insulin in a type 2 diabetic? The way I do this, and similar in some ways to type 1, is one step at a time. I always tell my patients diabetes treatment is a marathon. It is a long-term thing that we're going to refine little by little over the next months until we get it right. And so what I tend to do if we're initiating insulin, you take the orals that they're on. Oftentimes they can stay on those. So like metformin, unless their kidneys are having a problem or they have massive diarrhea or something, the metformin stays. The GLP or the DPP-4 antagonists can stay, the Januvia and those types of things. And so you can have that conversation with them. And so you have them on their regimen. It's not good enough. So step one for me is just initiation of low-dose, long-acting insulin. The good thing about long-acting insulin is 1 shot per day, and it lasts all day long. Another thing that's good to help tell patients is to show them the insulin pens, because I think a lot of people have this idea that they're going to be drawing up insulin out of a vial and they're going to be giving themselves injections with a needle and syringe, and it's so much easier than that to just have the pen on your thigh or in your stomach, push a button, and that's all there is to it. And so starting that type 2 patient on insulin, what I'll tend to do is say, we're going to start you on insulin. Now there's weight-based dosing. There's all sorts of ways to choose that first number. I tend to just start low and have the patient titrate up over time and then check back in a few weeks to a month. And so my general system would be to say, we're going to start you on some long-acting insulin. It's 1 shot a day. Why don't we start at 10 units? Okay, so tonight you go home, you're going to get the pen, you twist the top to 10 units, and you give yourself 10 units of insulin. In the morning, you check your sugar, okay? And then what you're going to do, my instructions are, you're going to increase the insulin by 3 units every 3 days until you either hit 50 units a night or are seeing sugars less than 150. So a morning sugar less than 150 for me is the bench line for we don't need more long-acting insulin. And so it would be, patient goes home, they do 10 units of insulin, they wake up in the morning, they check their sugar, it's 202. All right, they do the same thing again, 3 days in a row at 10. They look at those numbers and say, I was never below 150 at 10 units. So then you start 13, so you go up 13, and then you do 13 for 3 days. No, I still didn't get down below 150. And then you go up to 16 for 3 days. And then you go up to 19, and then you go up to so on and so forth. 3 units every 3 days until one of two things happens. Either you start seeing less than 150 in the morning, in which case stop where you're at, or you get to 50 units. Once a type 2 diabetic is at 50 units of insulin, chances are ratcheting up the long-acting insulin isn't going to help all that much. Remember that type 2 diabetics are insulin resistant. You can ratchet that dose. I've seen people up to 120, 150 units of long-acting insulin and still not doing well. So once I get to 50 units, I say it's time to address the mealtime sugars. That long-acting insulin is addressing that baseline sugar, but when you eat and your sugar spikes, it's not helping to bring it back down again. So then step 2 is to initiate short-acting insulin. So they're doing their 1 shot. Let's say they get up to 50 units. They're still not well controlled. And so now they do their 50 units at night, and when they sit down to have a meal, they give themselves a shot. How do they know how much to give them? There's 2 ways to go about it. One is just simple sliding scale. You check your sugar. Depending how high it is, you give yourself a number. So you write this out for them before they leave, and you say if it's between 150 and 200, give yourself 3 units. If it's between 200 and 250, give yourself 6. 250 to 300, give yourself 9. 3 to 350, give yourself 12. And then you have them do that. They come back in 2 to 4 weeks. You look over their sugars and see, oh wow, we're not even touching it. We need to go higher, etc. Now that's a sliding scale insulin. The only problem with sliding scale insulin is you're chasing your tail. You're only giving enough insulin to bring the sugar from where it is, say 200, back down to the 150. You're not covering the food that you're about to eat. And so the ideal way to do short-acting insulin is where you give a certain amount of insulin for the food and a certain amount of insulin for the scale. And so someone who's doing it perfectly would sit down to eat. They would look at their food and say, okay, I'm having a burger and french fries. I know the bun, each bun is a carb. I know the fries is a couple carbs. So there's 4 carbs in this meal. Therefore, I need 10 units of insulin for the food. Check my sugar. Oh, it's 250. I need another 10 for my scale. So I'm doing 20. So they give a dose for the food, a dose for the scale. If patients aren't up to calculating the carbs and how much per carb, I just say give yourself 10 plus. 10 insulin, 10 units for the food plus your scale. And if that's not working, you can go to 20 plus or whatever the case may be. So eventually they're on a single dose of long-acting insulin until it's up at 50 units. If they're at 50 units and still not doing well, then they're doing mealtime doses of insulin, which is determined both by how much they're eating and what their numbers are when they check. And step by step like that, you help them go through that. So I hope that's helpful. If there's any questions, certainly leave it in the comments below, and have a great day.